Hello, all. Good evening and welcome. AA boys are back here to welcome you all once again. Today is a big day, and we have Dr. Vivek Hegde sir with us tonight. Welcome, Dr. Anand.
Welcome. Thanks a lot, Abhishek. Welcome, everyone, and a very good evening to everyone.
So I hope you people are enjoying the masterclass to the fullest. We have Dr. Vivek Hegde sir tonight. Without wasting much of your time, I would like to welcome Vivek Hegde sir on the stage. Good evening, sir, and welcome.
Thank you.
Good evening, sir. How are you?
Yeah, good. Thank you so much. Thank you.
It's an absolute honor to have you with us, sir. I guess today we have the superstar of Indian endodontics with us. Sir is truly someone who has taken our Indian endodontics to the international level. It's a absolute privilege for us to host you at World Dental Association, sir. A brief introduction about sir before sir kickstarts his session. Sir is currently the vice principal and the head of department at M.A. Rangunwala Dental College, Pune. He has been the president of Society of Oral Laser Applications, that is SOLA, that is director of Indian Board of Endodontics, president-elect of Indian Endodontic Society, faculty at the University of Vienna, editor of various journals, and past vice president of Indian Academy of Conservative Dentistry and Endodontics, Indian Endodontic Society, and Indian Society of Prosthodontics, Restorative, and Periodontics. I guess there is nothing left now, anything more to do than this in Indian endodontics. So you have covered everything. Sir has been conducting courses on basic, advanced, on the use of microscope since the past decade. And I guess he's one of the best persons to be teaching microscopic endodontics in the country. He has lectured extensively nationally and internationally. Sir was the Indian representative in the International Endo Masterclass, which happened way back in 2017. Sir was the country representative in IFIA 2018 at Seoul, Korea. Country speaker at Asia Pacific Endodontic Conference 2017 at New Delhi. Apex speaker at the annual session at AAE 2016 and at the first International Endodontic Congress in Dhaka, Bangladesh 2018, and much, much more. And above all, sir is a experienced practitioner, a passionate teacher, I can vouch for it, and a proud father. So it's a great honor, sir. The stage is all yours.
Thank you, Abhishek. Thank you, Anand. Thank you, Akshay and Saurabh and the whole team of World Dental Association. It's an honor also for me to be here. I've been seeing you the way you all have been conducting number of webinars on varied topics. I think it's been going very well, and I've been enjoying it also. I've tried to catch up on many of those webinars that you've conducted in the past. Today is my chance, and thanks for inviting me here. I know there are many topics that are very dear to me, out of which one of them is Obturation Simplified. Anand knows it very well, so he told me, sir, I want you to speak on this particular topic. I purposely use the word simplified to tell you all how we could actually simplify each of those procedures. So let's go and see how we could do one by one. If you go back to the history, we all have read about this, that the oldest root canal filling was in 200 BC. It's told about 2200, maybe 10 extra years now because it's one of the older books. So this was what was seen to us. The reason I put this picture is, no offenses to anybody, but even till date, I sometimes get to do a repeat root canal for some of the fillings that are really short of apex. Much shorter than where it's supposed to be. It may not be as short, but there are cases which I've seen this way. In today's modern era, I think we should actually wake up to the fact, and you see such long teeth, supra-erupted a little bit, the first molar. You know this length of the teeth are definitely more than 25, 26 millimeters. You need to try and work around it. Sometimes, you can't possibly rubber dam the same tooth. So you need to go one tooth behind with the clad like the way I did here for better access, for better visibility. And then we ended up doing a down pack and then a backfill and then completed the procedure. I'm going to not only highlight on this one step of procedure, but slowly, if you understand, it's going towards this. So for all those beginners or initial starters, I want you to start thinking a little different of why I'm speaking about it. So what we do is, I get a common question from a couple of my participants or some doctors who want to know from me. They ask me, Doc, I've done a very good obturation and yet I don't see a good healing. Let's understand one thing very importantly. Obturation to the root canal space or gadapacha to a root canal space is like how suture is to a wound. You have a wound, you approximate it. The suture does nothing. It only approximates. What helps you in the healing is the initial part of it, which is when you medicate a wound, when you irrigate a wound and approximate it well. That is what is needed. The point I'm trying to tell you here is obturation is less important. It's important, but less. It's only a means to the end. What's very important, or most important, is a step known as cleaning and shaping. Of course, not to ignore any other steps from initial access till the core completion. But the most important step, I feel, has to be on cleaning. If you have done that step well, rest all will follow. Like I get some questions sometimes about the same thing. So like I still tell you, don't bother with the gadaparcha. That's why this picture comes here. You see this here, the picture of pre and post. We have completed a root canal. I went through a crown, removing a post for a tooth. And the next tooth was non-vital and we ended up opening a root canal. Just a cobalt up, no crown done. See what happens in 2 years. If you do root canals well, it's got phenomenal potential to heal. Now, this second case that I'm showing, which is 18 months old, this girl, a young girl, was a battered child. She got hit with a big stick and she comes running to us showing it, saying that teeth are mobile. It's an acute condition which looks as if there's a lot of bone loss. All what we did was a root canal treatment, and believe me, you see this radiograph, you'll understand it's not a new case. This was one of those cases in 2001, close to 20 years now. Convinced me root canals are so powerful that you believe in your root thirds, the apical third. In fact, I didn't have any lateral fillings here. I just was short of apex because those days we believed in the apex locator, which I had, and I thought I was short, but I still completed. But it's seen the 18 months. Of course, if you see this case, it was splinted. That's why you see the dots here. The splinting has happened, but from here to here, in less than 18 months, it's a good fill with a good crestal bone appearing. Many reasons to the success. The age of the child, a young child, it bounces back so beautifully. Here, okay, we've used root canal obturation. What about these cases? These are few cases who disappeared after I opened the root canal. I removed the crown. I gave a core built up. Like when I say core built up, it's an interim seal I'm talking, with a cotton in between. Now we use a Teflon. Some people use sponge there. I gave a good dressing. 8 months later, this patient comes to me only because that interim filling cracked in between and food was getting collected. When I took a picture, you see here, from here, such a big lesion, you will realize it started to behave. I have not completed. My intention was not to wait for 8 months. These are default cases. Another case here, we used to use this calcium hydroxide sticks, opened a root canal. I sent this patient. The patient went abroad for an assignment. I thought the patient would complete the root canal somewhere else. The patient could not do it for some reason, came back to India to complete it in Pune. Again, a very old case in my early days. And see what's happening here. What do you call this? The root is not filled yet. And see this. This root canal failed to an improper root canal done on one tooth. The infection spread to the second and the third. All this is terrible. In today's day, especially for youngsters, I want you all to start thinking about the entire concept of root canal, for which you need to understand what's a root canal. Why is it so important? Root canal is a hideout. Just little brief on it. All what you need to understand is, you're all bothered about the periapical lesion. It's a disease by itself. Don't bother as much. What you need to understand is the last 3 to 6 millimeters of the root end, because that's where the army of microbes stay. That's the load. You need to mechanically shape it and then clean it. Once you do that, believe me, root canals start to heal. Opening the top, opening the middle, going to the deepest portion is only a step down technique or a crown down technique. The entry part is not as important. Middle may be less important. The most important part of the root canal always is in the last 3 to 6 millimeters, which we should understand. Because bacteria will come and hide in that space, and that's the space which is least understood, highly overlooked, and I've seen a lot of dentists never give importance to this. I did the same in the earlier days. Whenever I reached the apex, I said, okay, done, my master cone's chosen, immediately mix the sealer, and I want to obturate it. Done with the story. Today, my whole concept has changed. When I reach the apical third, that's when root canals begin for me. The shaping begins. The cleaning is much after my master shapes. Till then, what cleaning I do is just for cleansing and taking things out. It's not sterilizing my root canal. It's not disinfecting my root canal. So you need to understand this concept. So coming to today's obturation topic, of course, I won't be covering on any other topics because I had seen some of the good speakers, dear friends, some of mine, who have covered those topics. So we'll cover some of the common topics. The commonest technique being the single cone obturation, the so-called glorified technique. I don't believe in this for the only single reason because the cross-section of the root canal and the gutta percha never match. The cross-section of the root canal is never circular and the cross-section of the GP is always circular. We are only trying to enlarge the diameter to certain size, hoping that the apical exit, which is also not circular, comes as close as to circular so that a GP point goes there, gets corked and becomes a good apical seal. I'll come to that a little later. That's one of the only reasons why I don't like single cone. Lateral compaction is definitely an acceptable technique. But then there are better techniques today. The vertical compaction, newly called as thermomechanical compaction or thermoplasticized compaction, in the form of a down pack or a backfill. Sometimes it's become hybrid because now bioceramic materials have come in the form of sealers or in the form of apical plug and then the remaining gutta percha. And also you have a core carrier based obturation. These are the few common techniques all the dentists worldwide will use. If you ask me, one of my favorite technique has to be a down pack and a backfill. So let's go with all these techniques one by one. The most, or if you see the word compaction, I saw it here. It's not called condensation anymore. Earlier, I know the books told us lateral condensation or vertical condensation. You only want to condense, say, gas. And gutta percha is not it's not a gaseous medium. It's a solid or a semi-solid. So what you need to understand is you have to deform the material. When you deform the material, it's going to get molten material, softened material, and then compressed. Such a process is called compaction. And that's why the condensation word is out from the books. There are many classifications. I don't want to go into all that. I like this one classification from Franklin Tay and Pashley. This is what they try to say how to do with the newer materials. It also will go to say about some bioceramic materials. Like I say, I know the crowd is, who are viewing me are more of clinicians. So I want to speak to the audience. I will try and apply the theoretical knowledge into the clinical applications or practical applications. First and foremost, we need to understand, we have prepared the root canal. The canal is ready to accept filling materials. Now, when you have to apply a filling materials, the first and the foremost important step at the root end is to prepare a matrix. The matrix should have a constriction, should have an apical step or a stop. That's the most important requirement. You see this picture? It's got a flare, it's got a parallelism, and the objective of you getting a cone fit, because it should be the master point. The point that goes in should go and get corked. That's what I want you all to do. The first and the primary requirement, when you say master point or the master cone, That's the only one cone that goes at the root end and gets stuck there. To select such a cone, you need to work that way. It always starts from the preparation. I always get to hear from some of my students, "Sir, I had prepared it so beautifully, but my obturation has not come out well." There's a saying here, your obturation is only good as your cleaning and shaping. Just like the way sometimes you say, "My impression of my tooth preparation has not come out well." Your impression is only as good as your tooth preparation. It can't be better than that. So please spend time on a good cleaning and shaping. That's very important, which means many a times we shape, we try to clean, but if you don't apically clear it, there's a lot of dentine mud along with your biofilm or your smear layer or whatever it may be, going to clog, sometimes in the form of an apical hard tissue debris. So my only request to all the clinicians viewing me here is, please spend time to do a good apical clearing. It's a very, very important step. Now that suppose this particular condition, clearing is done, my preparation is done to a certain size, I need to select a GP, a Gadaputta. I do not want to be spoon-fed, which means suppose I have prepared this canal to say F1. F1 is what? A 20 size apical diameter and a 7% taper. Between diameter and taper, diameter is more important, not taper. Because diameter is fitting at the apex, the apical fit. And taper is a lateral fit. Imagine if it fits well on the side, the taper, and the tip is not at all binding. What's going to happen? It's got a matter of time. We're all going to have periapical ingress, along with it bacteria, all the microbes coming in, a good culture media, a gamut of infection, repeat, refailure, then it goes for a retreatment. So if you've done all the steps well, obturation is easier step. Like Franklin Wayne had told, it's what you remove is more important than what you fill. But you need to fill. There are conditions and techniques or papers on what if you don't fill a root canal. It might work for some time. It works, of course, like I showed you those cases where it's healing, right? Even without an obturation. The concept is how good a coronal seal you have. That's another good important point. The coronal seal between dressings, interim dressing, or the permanent core built up so-called should be a minimum of more than 4 millimeters. Minimum. It can be 5, 6. I can watch for anything more, but not less. There'll be leakage happening otherwise. And that is what's called as coronal leakage. That's another reason why sometimes root canals fail. So coming to apical gauging, I have prepared F1, just an example. Companies will provide you with the spoon-fed points, a ready-made point. They'll give you an F1 point. You have this canal preparation. You put an F1. Everything looks nice on a radiograph, and you possibly would seal it. These points that I'm talking, the GP points, are not 3D printed as of now. They're hand-rolled. Even if they're machine cut, they're not standardized the way we want. So I wanted to do one extra step in obturation. The only step I'm asking is please customize your point. You can use a non-standardized point. You can use a standardized point. The simple technique for me would be, for beginners, start with the standardized point. Like I said, there's a diameter and a taper. What I want you all to focus on is the diameter. The taper can be anything less. So to know my gauging, I will use some instruments which is less than 7%, which means my file will go and totally bind truly at the last 3 millimeters of the root preparation. Of the canal preparation, at the root end, it's going to bind. Because the taper being less, rest of the area is going to be floating. If the preparation is 7%, I have to use some instrument that's less than 7. So I'm going to use maybe the simplest hand instrument, a 2%, my safest instrument. I can use a 4% also, a 3%, a 5%, whatever it's available. But in hand instruments, a simple stainless steel instrument at 2% is good. I took a 20. 20 goes to the full length, and you see it here, it's matching perfectly. So I'm good to say 20 is suiting. So my preparation that I made with F1 is perfect. But I need to confirm that. So what do? I take one more file which is just larger than this, which means a 25 comes in. When a 25 comes in, this is just an example, okay? Even the 25 goes to length, which means that 20 which went was wrong. If 25 is gone to length, 25 is a file which is better fitting, is a larger in diameter. Why it happened? I don't know. There are many reasons. Maybe there was a flare in the canal already. Maybe you stayed with the rotary file longer. Maybe you did a brushing motion instead of going a non-brushing way. Whatever is the reason. Now the canal is opened up. And there's a little wider apical diameter. So you need to think 20 is a wrong GB to choose. The diameter now is 25. But you need to confirm even this. To confirm this, I will take one more file next. Here in this example, the 30 is not going to length, it's shorter. So between 20, 25 and 30, hand instrumentation, the best fitting diameter was 25 and not 20 and not 30. So I would ask you all to pick up a GP point which is red color, which is 25 in diameter, and choose it for this canal in spite of you using an F1 which was 2007. Now if you choose a GP point that is fitting so beautifully there, which is called a tug back, it's not a snug fit, I put it that way, it's called a snug fit now because we want something known as a linear resistance, not a point resistance. In today's preparation, you'll definitely get a linear resistance. The concept goes this way. Just an example. Think of this. We buy all these whiskey bottles or wine bottles, right? The older they get, the more we pay. Yet, not a drop evaporates. If it does, we wouldn't be buying it and we wouldn't pay that kind of money. The point and the reason is, even those bottles are corked. The lid is a cork. And the cork is some form of garaparka. That GP that corks on the top is preventing the evaporation. It's easier said than done. It's just a concept. Think about it. Suppose I ask you to use a garaparcha, to use the same corking principle to the root end, where would you be? Like I said, it's easier said than done, but think of this concept. That's what you should try and get. That's why I want to melt the garaparcha as close as to the root tip. When I say root tip, it's a minor diameter, short of tip, of course, till the root working end I'm talking, and melt it, then molten material I want to manipulate it and get a good seal to suit the cross section the best that it can. So that's known as apical gauging. Just few examples. Martin Trope had shown this case in 1999. You know what? This case in 1999 is not a bad work. Good diameters, good tapers. Of course, today we wouldn't go so larger. That's a different concept. But those days with those files, I think he did a lovely job. But this tooth went for an extraction and a post-mortem was done. I learned a lot from this case. Distal root, even though the obturation looks nice, here the distal root, it's not suiting at all. Look at this. 1 millimeter short of apex, GP cross section is round, canal is this way. 3 millimeter short of apex, there is debris, there is leakage happening, there is a gadapartika that is circular. What about the mesial roots? The same story is not different. He concluded by writing saying that there was necrotic tissue, there was debris in this tooth, this incorrect diameter. These are the few reasons why this tooth possibly failed. I think it's a good take-home message. 2006, there was a tooth that I treated. It was a repeat treatment. I went to diameters of size 30. These were blue colored GP points. Then you used to get these colored GP points. They're harder GP points. I used them. I did a repeat treatment. The minor diameter is sealed there, and that's the major diameter. And you see what? the tooth went for an extraction. Because we've done treatment, somebody did a treatment once, I did a repeat treatment once more, and now we've lost the tooth. Fair enough. I don't mind failures. I am ready to accept failures, but I need to know the reason why. So all those teeth that get extracted, in my knowledge, I pick the tooth in my free time. I will do an autopsy or biopsy. That's me. To just find the knowledge. I will section the tooth to find out. Maybe there's so many reasons I found out, There have been sometimes lateral canals, additional canals, cracks, fractures, folds, missed canals, whatever it may be. So these things have happened even with me. It's a rich source of learning. Mistakes are pardonable. But if you don't learn from your mistakes, then you're not growing, right? So I wanted to understand this way. That's exactly what happened to me. This tooth failed, it's okay. We went to the next step, patient was okay, we were fine, but I learned a lot from this case. So I want to do an apical gauging, and to do an apical gauging, just learn this. You need to understand to have the inventory with you. This is a medium non-standardized point. In this video, you need to see that picking a point, and then we are trying to use it. The size of the GP that we want to create, the apical diameter was 40. So I put it in this gauge scale, it's called an endo gauge, push it up to where it goes, turn it the other side. Whatever comes out from the other side, please use a 11 number blade, a Bart Parker blade, and clean cut it. Don't use a scissors, please. You can't cut it clean. Now I've customized this Gadaparcha to a diameter of 40. And then I don't like this endo block when it's a greater taper point, because I'm going to show you the endo block. See here, it's not even touching, because on top the taper is too broad, because of which it's binding on top. That's what I mean by telling you gauging. You want the bottom to go down as much as possible. In a 6% or even larger tapered points, the top touches. But this endo block inventor is smart. You know what he's done? He's made a scale also on the side. So I'll take this point and measure it from the side. This is about 22 millimeters. And this was my department earlier. And then I'm taking it to the canal. One clinical tip here is, please take Gadaparcha into the canal in a wet condition, not a dry condition. I've seen some clinicians drying the canal to put a Gadaparcha in place for the master cone radiograph. When you select a master cone, there are 4 tests. One is known as visual test. That's your reference point, the point you mark to the incisal edge in this case maybe. Second is known as a clinical test. That is this test I'm talking. Third is known as a radiographic test. And the fourth, radiograph is up to where you reached on the X-ray or the radiographic picture. The fourth is known as a tactile test to see if you got a snug fit. So in the clinical test is what I'm doing now. Why am I asking you to do this? 2 reasons. One is because in wet conditions, when this GP point goes inside, the liquid will simulate to a sealer condition, because when the GP finally goes inside, it goes to the sealer. Coincide your reference point, so your visual test is also confirmed. The biggest, and the radiographic test is here. The biggest advantage is, you know what? When the GP point goes in a liquid of sodium hypochlorite, say 5%, you put the master cone inside, you bring the sensor, bring the X-ray cone, make the radiograph. By the time you see the picture, take things out, take the GP point out, automatically the GP point gets a 1 minute of disinfection with a 5% sodium hypochlorite. You're ideally supposed to disinfect a hypochlorite. It's also called as the GP point sterilization. I don't know if truly you can sterilize a GP point. So we disinfected a GP point. Earlier, we used to take a Dapon dish, put the GP point there for a minute. You don't have to use. You can get double whammy here. It helps you do a clinical test. At the same time, it's giving you a sterility. That's what I want you all to understand. Please do that. It's important to understand that. Never ever use a scissors. Under the microscope, see these pictures, how the GP point will look. Normal eye looks nice, but you use the scissors and cut, you're going to drag it. Instead, use a GP point that is a little different, a little larger if it is going beyond. You'll only cut because it's going beyond, right? That's why. So don't use a scissors, use a blade, a BP blade, a Bart Parker blade, 11 number is the best one. All right. Whatever preparation that I've done, the favorite Gadaparcha point, if it is standardized, has to be a 4% point. I might do a preparation with a 6%, a 7%, maybe an 8% also. I don't like 9% tapers. Diameters we'll discuss a little later. But tapers, I will always keep it to a taper which is about 6. That's what I prefer. Maybe 7, but not more. Now, why do I prefer a 4% GP point? I prefer a 4% GP point because when the GP point goes straight inside, it will go deep down and get stuck at the point where the apical diameter of the matrix has happened, which means the GP point is a free-floating GP point. If I take a corresponding GP point of the same size and same taper in curvatures, it might bind at the curvature, and I may not be able to take it to full length. You may wonder there's going to be spaces, there's going to be gaps, or whatever. I don't believe in glorified single cone obturation. The same treatment, the same GP point that I showed you, all of these have been obturated with a down pack and a backfill. There are times when I would try and add additional cones. I'm not telling you to fill the whole thing like a lateral compaction, but if you find it really loose in larger canals, it's advisable to put an additional 1 or 2 cones so that when you cut the GP point at the levels that I'm talking when a little later, this way, you might tend to pick the whole thing out. We don't want that. When I said I don't like the customized, the spoon-fed, same tapered, same diameter master cone to the master apical file. Because when GP points are made, we've done studies in the department. We've done by weight, by volume, and a couple of other studies. It's an in-house study. And we always found, suppose I took a 20 or a 25 size GP point of a 4% or a 6% or whatever it is, from any company. We compared many companies, of course. There's always been a GDP, a geometric difference of plus minus 3%. So in a box of, say, 25 size 4% GP point, we always found the GP point was not 25 all the time. It is 22, 20, 24 or 25, 26, 27. If the GP point is larger than 25, it's definitely not going to go. And if it's smaller, it's not going to fit well. So that's why I said you need to customize your GP point. Please make that one step in obturation. That's the only most important step. So for me, mostly it's a 4% GP point. Look at this case. We did a pre-endo. We prepared the canals, the 4% GP point, obturated it there, and that's the floor of the tooth. And that's the completion. We managed to get a decent good filling here at the end of it. And the most important requirement is a good pre-endo here, please, which we should not ignore. That's not my topic. I'm sure some speaker has spoken about it. And a very good interim dressing. In between, you can leave something like a Teflon and send this patient back to the referring dentist. If you're the person going to complete it, you can build it up with a core built up material or a post if needed, and then complete the core built up. So another case of 4%, you see this is a third molar. We had to keep this tooth for I don't believe in keeping a third molar in the mouth, but the patient was an old patient where a denture clasp was lying on this tooth. So it was a very critical thing to save this tooth for the denture. So we did a root canal there, and even with the 4%, from there to there, if you see, we still managed to get good apical splits. Okay, but if you want to get that good apical filling or lateral filling or axillary canals packed well, then you need to clean and shape well. And most important is cleaning. You see this? There are 4 canals in MB2 also here, but you need to spend a lot of time using some chemicals towards the end before you start obturating. Now here's a preparation. This is a sequence from a Protaper Universal series. You would prepare, this is mechanical preparation. Instruments produce shape. They do a good preparation, no doubt. But the cut material is actually slapped back into the same dentine that is having. It's collecting the same material back. So all the pores, the microporosities, the lateral canal openings are all going to get sealed with this debris or the smear or the biofilm. That's when you need to try and clean it. Here I've prepared this premolar to size 40, a 4% cones there, but see this, it's in wet condition because I'm going for a radiograph maybe. I'm showing an extracted tooth where preparation was done. Large GP points are going in, but the canal under the microscope looks this way. When I put a GP point, the GP point will go into both these canals. But definitely this is not looking nice with white debris all around. And this is looking with a clean isthmus and clean canals. So this is what we have to achieve if we want to get a good clinical success. So for which I would definitely recommend all of you to think of a chelating agent, which is liquid EDTA. But the most important step definitely will come is you have to activate a chemical, a medicament, a sealant, a solvent, even an etchant maybe in a non-vital tooth. Because when you put any chemical, you're going to have something known as a vapor lock effect. It's a debate on vapor lock word per se, but understand one thing, there's going to be vacuum, there's going to be suction, there's going to be negative pressure, there's going to be air bubble sometimes, which means your chemical is not going to contact the dentine the way you want. Which goes to say there's not going to be any chemical action in some places at times. So that's the sad part. If the chemical like sodium hypochlorite is not touching the dentine, you want to eliminate both the organic and the inorganic content, right? That means you need a good soaking of the dentine. I'm just going to show you these two pictures. There are so many studies. O. Peters has done studies on this. Matthias Zender, Frank Paquet, you name them. A lot of clinical studies on irrigation. Hapasalo, Baumgartner, Anil Kishan, many names internationally I can go on telling. They all have done studies. Most of them have said only one thing. This is before canal preparation, a micro CT sample. This is after preparation. Before and after, if you see, you will still end up seeing a lot of green areas which are unprepared. And many of them concluded saying that more than 30 or 35% of the root canal still remain uninstrumented. That's the sad feeling, okay? It's not nice. The instrument may go in and out because of the convexity, the concavity, the undercut. The rotary is going only in that motion, right? So there are areas which have got bulges, which have got convexities and concavities. So there's not going to be equal contact. In such cases, only your chemicals will do the trick. And if the chemical has to reach there, you need to activate it. And that's what we will look about. To activate, there are plenty of options. I would jokingly tell, how much money do you have? If you don't have much money to invest, start with these. You have a hand filing technique. You can use the same irrigation needle. You can use a GP point to take it in and out maybe. If you have some money, you can invest into some rotary drills, into some activators, into some endofinishers. If you have some more money, you can go into, say, ultrasonics, into some negative pressure, or into some lasers. It's called photon-induced photoacoustic streaming. You see here, all the debris will come out there in no time. So all I'm trying to show you is, we're trying to use a laser called PIPS. It's photon-induced photoacoustic streaming. See the debris. At a sub-ablative range, you're trying to use it. This is one of the best methods, I feel, where you can clean it at the entry point. It actually moves the chemical to entire length. One of the second best option, if you ask me, will be here. This is something known as an EasySafe ultrasonic file. And there are many techniques that you can choose. So we've done some extracted tooth work on an in vitro studies, again in the department. We managed to get samples. I'm going to show you samples from only one group. This is the laser group. It's very easy. In fact, on most of the groups, we got coronal third clean, very nice, like the way you see fresh cut open dentinal tubules. Middle third, some of the samples gave good results, some didn't maybe. Apical third, most of the groups could not manage to give good results. This kind of fresh, open, cut dentinal tubules, who wouldn't want to get? Laser group actually gave us this kind of opening, wherein your irrigant, your medicament, your sealer, your molten gadapacha, everything can go in and interlock, give a good seal, a micro binding. That's the kind of obturation I would want to see. And that's when you'll get very good clinical success. So, just before obturation, now that you have activated, you need to clean the canal, dry the canal. If you don't have much money to invest, for beginners, you can lock the needle, use a suction, a syringe, and try and suck it out. A wide bore, like a calcium hydroxide needle, can be used in this canal. The gauge may be something like 18, 20, 22, 24, you can decide. But if you ask me, this would be my choice, where I would use a micro suction. When I'm working under the microscope, this is a C-shaped canal. My assistant is holding the microsuction, and I'm using a 30 gauge needle to irrigate, and see how it goes. So at the end, you wait for some time and dry the canal on its own. After which, you'll just need 1 or 2 paper points. So these are some of the microsuctions. I have got it built in the chair, but you can also put it into the simple high volume evacuator suctions that and hold it in the hand, and it'll just work the same. Even if you have done that, you still need to dry the canal with paper points. Like I said, if you don't get the dry canals like this, it's not done. You can't obturate. You need to get a dry canal at the end. Be it one visit, be it multiple visit. Call is yours. There are some cases I have used 4 paper points till I get a dry canal. Sometimes I got it maybe in second paper point. So the small trick is just try and do a circular motion so that the absorbent point comes in good contact to dentine, not only at the apical end, but also at the middle and the coronal end. And it's called an absorbent point. That's why, my friends, please wait for about 15 or 20 seconds with that one point. There was a habit in me where I take, I want to throw. It so happened that I'm using so many points, yet not getting a canal that dry. So then I slowly modified my trick, saying that let me put in the mesobuccal, let me put in the distobuccal, and then on the palatal if it's an upper molar. And then I remove the mesobuccal, then the distobuccal, and the palatal. By doing this, automatically I ended up giving the 20-second due that the absorbent point needed. So that's how I started modifying it. Now that you've dried the canal and it's ready to obturate, you need to pick up a binder. It's a sealing agent. That's what it's called, a sealer. You have a lot of sealers in the market. You have a medicated sealer. You have a non-medicated sealer. You have a zinc oxide sealer. You have a resin sealer. And then now the newer ones known as the BC sealer or the bioceramic sealer, the bioactive glass. So these are the ones are of much preference now, especially in the days where we have the COVID or the corona. I will tell you some of the advantages and disadvantages when I come to the slide that I want to talk about later. There are a few sealers that I like and I don't like. I'm not against all the, any company that would produce anything. There's my choice. And the picture that I'm showing you are those that I've used in my clinic. There may be more products than these. I know this presentation is a world over coverage. So I don't know which countries you have what type of sealers. But in India, we get these sealers. I've used most of them. So let's go into a small clinical tip, that never use the zinc oxide sealer, the powder liquid. I know it was used for a long time around the world. Even in the lesser countries or the smaller towns, it's still used. But believe me, this never sets well. And you never get a creamy consistency every time the way you want. If this you're using, I think it's time to get it out. It's not worth. And this is a good picture. This is in one of the clinics which I took a permission of a place where I was taking this picture. It's looking dangerous. You know, maybe earlier years when I started working in one of my consulting practices, it used to look this way. And then when I started work, it was maybe organized well, and then it becomes everywhere. It's like a war zone, you know. So in fact, I asked my patient, how did you feel the experience after the treatment? And he made a big joke out of it. He told me, Doc, this looks scary. It looks like a war zone with all the instruments everywhere. And most important thing is what? This particular spirit lamp we used to use. We used to keep cotton, wet cotton actually, because it doesn't flame and catch fire or something, you know. He made fun of this and he told, Doctor, this looks like an Aladdin's lamp. And that hit me somewhere. And from that day, this is early in 2000, of course. From that day, I made it a point. I might buy a Bunsen burner. I might buy an, oxyacetylene flame gas torch, because downpacking instruments are not popular. But I'm going to show you a downpack instrument today. We don't use any of these. We have rapidly upgraded ourselves long way back. A sealer coating is a must. This is my spot check, I say. I have to see a good amount of sealer. But you know what? I'm using an absorbent point. I don't want you to use an absorbent point here, because the fibers of the point, sometimes when I looked under the microscope, I realized they get retained behind. We don't want that, right? So that way, this is of course lateral compaction. We'll see that video is better somewhere. So a master cone with a sealer is a confirmatory radiograph. We have to see that. So see that I don't want you to use a lentillo spiral or a bidirectional spirals too. You need something to carry it. One of the nicest way for me to carry is a Garapacha cone that I want to carry it into the root canal and rub it in inside out motion. I'll keep minimum sealer. In fact, I don't mind taking a bonding agent brush, like an applicator tip, and removing the excess that's there in the floor. But I would want to make a picture to see under a microscope if that canal is coated well. That's my spot check. Once it's done, I go for the next step. So if you ask my most important radiograph, it's not the post-op. This may not be the most important radiograph, even if I filled it well. My most important radiograph is this one. You know why? My GPs are not seared yet, but that single cone has gone. There are voids here. We will fill some additional cones and take care of that maybe. But master cone with the sealer becomes my most important radiograph, because I've taken a trial with this Garapacha points. That one last time when it's going in, if it hits the wall, if it bends and buckles, my reference point is on the top. I'm looking at the incisal or the occlusal reference. It looks perfect, right? And if I've not made a radiograph, and if I've sealed it, after which if I make a radiograph, oh my God, it's not reached where it's supposed to reach. Remove everything again and repeat it. It's not going to help me at all. So make it a point to make that radiograph. If you want another radiograph, you decide if you want it or not. This case that I'm showing you now, of course, this is a CBCT picture. We didn't need a CBCT for this case, but this happens to be a very important patient for us. One of my good friend's mother-in-law. Now, he did a root canal for her, and he found the pain was not going. That's when he said, Vivek, I don't want to take any more chances. Please take over the case, help me out. So we took up this case, and you know what? This is a radix case. So I'm going to show you the pictures here. That is what he had done. This is the radiograph he referred. I know there's a cone cut at the apical end, but this was good enough for me to understand there's a lesion developing there, and there's a short curved root there called a radix entomolaris. And I made the axis cavity. You know what? The axis cavity is wider actually on the mesial side. But here on the distal side, it's wider. That's the kind of axis cavity we ended up doing. In radix cases, most of the time, the canal climbs the wall. It's called a shamrock preparation when you move the wall away to bring the canal down. That's exactly what I had to do here. Fair enough, we found that extra canal, and I also obturated. That's not what I want to talk about here. What I want to talk about is follow the arrows. This is what I filled in the red color GP point. Now you see what he has filled is the yellow ones. I don't think yellow is a color to fill a GP point. Yellow is a 20 color or 20 size. It's too small a size to fill. More than that, what he has used, he's used a resin sealer for sure. It's looking more yellowish because of amide. But if you see this particular Gadaparcha is floating in a bed of sealer. If you ask me, the sealer should be in film thickness, minimum thickness. Maximum should be Gadaparka. The core is GP. That's what I want you all to do. So this is like a glorified single cone obturation. If something has to fail here, the first point of breakage is not the GP, not the dentine. The weakest link between the Gadaparcha, the GP and the dentine, the GP and the sealer and the dentine is a sealer. Like they say, the weakest link between the composite, the bond, and the dentine or the enamel is the bond. So this binder will be the weakest link, and if it is in millimeter thickness, then it's going to definitely break down. So when you talk of single cone obturations, yes, in today's time, you can possibly do this. I don't believe in single cone. I'm not seared this GP point. I'm just looking for apical controls, and then I will sear the GP point. But this is a BC sealer, a bioceramic. A bioceramic sealer is more thicker in consistency. You have to work quicker, please. Maybe you can mix it canal by canal. I'm okay with that because you mix it at one time. By the time you complete all, it's going to be harder. There are clinicians, good researchers talking about put just one cone just to stabilize like a reinforcer. So with bioceramic sealer, maybe the concept that I told of breakdown may not happen as much, but I'm still not comfortable. I will still put this additional cones. See this? Even though there are 3 canals, I put some more cones to just give it a little better packing. And when I sear it, when I cut the GP point, I will not do the conventional, my choice of doing a down packing and a backfilling. I would prefer just to sear it on the top at the entry point. In short, when it's a bioceramic obturation with a GP, please choose something what you did for a lateral compaction. Reason being, bioceramic sealers do not like heat. When you give heat or a hot instrument, you're going to melt the GP for sure, but you're going to crack the sealer. These bioceramic materials need a lot of moisture to set. If you take out the moisture with the heat, you had it. So please do not let the bioceramic material crack. So don't go far till the root end with the down packing instrument. That's my request. So we go to another technique called lateral compaction, because like I said, glorified single cone can only be with the bioceramic, which also I don't believe. I prefer a lateral compaction like this. Lateral compaction is simple. You put a master cone, you will take a spreader, you will take another cone, then you'll take another spreader, and then take another cone, and then you'll take another spreader, put another cone, another spreader. What you need to understand here is, when you do that, please select the spreader only in one direction. Spreaders are those instruments which are pointed instruments and smooth instruments. Pluggers are those instruments which are also smoother instruments but are flatter and not pointed at the end. You get 2 types. You get finger and you get hand. I showed you both in this quick video. It's a reduced video, a fast advanced video. But what you need to understand is you need to create space only on that one side. That's the trick. So quickly fill as much as you can, and with one hot instrument, just sear it off. And then give a vertical plug. These were the old techniques where I used to use the burnisher, an excavator, and all those. Today, I would definitely want to use one of these burners I started using a little later, but today my option would only be a down packing instrument. So a clinical case to show you all, when you create a space, I want you all to create space only on one direction. And when you create a space, you'll put, I would prefer to take a 5% spreader, a red color, and prefer to take a GP point which is one size less or a one taper less, and I'll try to put it there. You know what? That's a yellow color GP point. The spreader that I took was red color. I can also take a red, I don't mind, but this is only an additional packing. It's like a building up the core of the root canal filling, not the core built up. Don't mix up. When I took the spreader and created the space with, because it's minimum sealer, that space that is created is beautifully seen there. See that? So I want you to create the space so beautifully. Deform the spreader to one direction to about 20 seconds. The GP point, the master point, goes to one side, and that space that you see there, you will quickly take an additional point and put straight into that. You can't go wrong if there's less sealer, because sealer will not flow into that space. Again, you can create a space, put one more cone. If you're not comfortable, do canal by canal. If you're comfortable, do everything together. The choice is yours. At the end, when you sear the GP point in a lateral compaction or any technique, when you come to this level, see that you don't have GP point on the floor, crowded and filled, bulked up. I know there are some clinicians saying, let me see that tomorrow. And tomorrow when you're removing, you're going to use a burr. You're going to use a drill. That drill is going to cut dentine. You like it or not, when you use a drill on the dentine, 0.2 to 0.5 millimeters of unnecessary removal of tooth structure happens, which we don't want. Nobody wants to waste a tooth structure, right? Because once gone is lost. You're not going to get back. So my request to all of you is, if you can sear it the same day to the entry point or a millimeter or two into the canal, that's another concept where you can build a core from within the canal for additional retention. It becomes self-locking, short post it's called. All that can be done. If you end up keeping GP point on entire floor, when you put a bonding agent for a core built up to adhere in a resin dentistry, the resin composite is not going to bond to the floor. One of the reasons why your debonding and leakage will start happening. It doesn't bond to the pink spots here. It will only bond to the brown, yellow spot area, which is dentine. So understand, and in non-vital, the bonding is that much more difficult compared to the vital tooth. So please take adequate precautions. So we've seen the single cone, we've seen the lateral compaction. Now we are going in for learning about the root canal properly. A simple picture to show you the longest tooth and the shortest tooth. The longest tooth can be as much as 25 millimeters in general, and the shortest tooth can be about 17 millimeters in general. Variation may exist. I have treated a canine which is about 33 millimeters. If you divide these teeth into the parts, the crown is about 8 to 12 millimeters, which only adds to the length. What we are doing is a root canal, not a crown root canal, which means the entry point is not as important. What's important is the root thirds, which means the apical, middle, and the coronal, of which, if I will talk to you all this way, if this is the tooth, a joining canal, one single canal prepared full length properly, the other has been joining somewhere in the middle third junction. I divide this tooth into crown and a root, and you have the apical third, a middle third, and a coronal third. So you get it this way. So if you divide these 3/3, like I told you, the most important part of the root canal is always not the top, but the bottom. When I say bottom, the upper teeth, it might look the other way around. It's the apical third, the root end I'm talking about. So understand one thing, the apical third is the most important part in the root canal because that's the hideout, that's the zone of infection, that's where you need to clean and shape, and that's where you need to pack. If this is not good and rest all are good, sooner or later, we are in for trouble. So I want you to get a three-dimensional pack at the root end. That's why I believe in a down pack and a backfill. So if you see, I had done a preparation on obturation of the apical third. That was my favorite topic there. If you see all these obturations, I'm only focusing on the apical third. There are many teeth we have filled there. Sometimes your down packing instrument do not reach the apical third because of the curvature or because of the sizes that we choose, whatever it may be. Try and go as far as you can, but not farther than the apical third, which means minimum of 3 millimeters, maximum of 5 millimeters. That's where you can reach with a hot instrument, because you don't want to do untoward damage to the root or do other untoward damage to your procedures. After doing a down pack, after doing the apical third preparation, suppose these teeth are needing a post, you're sorted. See, in this case, there are 2 posts that have been put on this premolar, fiber posts, and you're taken care of. Like these cases may need a post, and then you need to take care of that accordingly. So your apical third, you're done with your obturation. The most important trick to have your GP point go into that is you should have a smooth transition zone, which means your master cone that you choose should be able to go there repeatedly and passively a couple of times in the curvature. A good clinician will always work on this transition zone comfortably well, which means the preps that you do in the curvature are the critical part of a preparation, which also goes to say he will see that it doesn't ledge first of all, it doesn't transport from there, and it maintains the conical preparation to the root end to form a good matrix. Now, to show you transition zones, these are easy, straightforward teeth, almost straight canals. But look at these teeth. Suppose I'm going to show you this canal. Look at the bends that this root has and the length after the last curve. Look at these, joining, splitting, and joining. These all can be tricky cases, which means if your preparation is not good, you're down, you're in for trouble. So, one of my favorite techniques, I know earlier Herbert Schilder gave this technique called as thermomechanical compaction, thermoplastic compaction in the form of a vertical compaction technique. Later in the 80s, late 80s, I think so, Steve Buchanan modified it and called it a down packing technique. So what we'll do is we'll just take the whole thing. Now again, I've used few of these, so that's why I'm showing you this. What I have at the moment is this BNL and this Denjoy. They are downpacking instruments. They're nothing but a heat pipe or a coil, which means now you have this corded device. These are cordless. I prefer these cordless devices. So you can possibly try and use these cordless devices. What they do is there's a heater in that, there's an element. You can choose to get the instrument hot at the tip. It can get red hot to maybe 150 degrees, 180 degrees, 200, 230, 250. You can choose based on the canal diameter and the volume. And that's what we do. Take the step up to where you want to go, cut off the GP point, take it out, and then work on the next step. Let's see how that happens. This is the textbook picture showing that your instrument will go only in the straight part of the canal. The more the straight the canal, the more deeper you can go. If there's a curvature in between, maybe you're troubled. I know we've got these night eye points, but I'm not too sure it will really go the way you want to. Because eventually, even though they are night eye, remember one thing. The instrument tends to hit the outer curvature, not the inner curvature. That's the story, even in a rotary file, unfortunately. That's why you need to mix with your hand and your rotary. That's a critical part of your preparation. All right. So now I showed you a couple of devices, and they've got a couple of tips from a pulp tester, which has to go very high temperatures to 550 degrees and all. We're not talking about that here. We'll talk about these tips. So you have a 30 size, a 35 size, a 40 size, and it can go on till about 60 size. And then in this company, you have something known as a medium large, and it can go on till extra fine. You have another company saying there's 43%, 55%, 66%. Why have these numbers come? These numbers have come only because I'm going to give you a chart here. With respect to 2D, a diameter and a taper, a 25 size preparation of 2% file. After every millimeter, if the tip is 25, if the 2%, at every millimeter there's a jump of 2%. A 25 becomes a 27, becomes a 29, becomes a 31. 3 millimeters from the tip. 35 size file, 2%, there's a jump of 2 again. 45 size file, a jump of 2 again, it's a 2% file. Now I take you to a 4% jump. A 25 size file at the root end jumps by 4 every millimeter. And a 6% file, a 06 file, jumps by 6. So 25 becomes 31, becomes 37 to 43. A 27, like an F1, jumps by 7. So 20 plus 7 plus 7 plus 7. Same way, 25 plus 8, because 8% taper, F2. And an F3 is 13.9. So it jumps by 9. This is just an explanation, okay? So what you need to understand is, I told you that you need to be 3 millimeters away at least from the root end. So the minimum you can be 3 millimeters away, and the diameter of the root end is 30 or 40 or average of 30, 40 or 45 or 50. That is why you have tip diameters that I've spoken about, which are starting from about 30 till about 60 with varying tapers. Tapers decides on which tooth you want to work. You can't choose a larger tapered file or a heated probe or a downpacking tip on a narrow canal. You're going to crack the tooth. The popping noise will come. That's the end of the tooth. If you take a thinner point to heat it and take the GP point out, the whole GP may come out. So there is a selection to be done. I'll come to that a little later. If you see here, these are those teeth that we have worked on a down pack. And these are some more. The next step will be a backfill. What you need to also pre-select and keep is pre-size, pre-fit, cold pluggers or condensers. These condensers are cold, which means one of my favorite is Buchanan pluggers for sure. They come in sizes, a pair, like 1, 2, 3, and 4. The thinnest to the largest. There are paired instrument double-ended. So you can use it in a size 30 canal, or you can go to a larger to 80 or 100 also. Which means you choose a size which goes to each of those teeth. Select one for the apical third which fits snugly good, not active of course, passively. Then one for the middle and one for the coronal. So these will help you choose. Now the first step is I put my master cones, we put the sealer. The first step is the heated instrument. I will take it into the entry point. And all I'm doing is searing it. I'm doing a cutting of the GP point, which I used to do earlier with, say, excavator or a burnisher or a condenser with less heat. So half-minded. So if I take, sometimes things come out even in the entry point. Here I have a thin probe, heated probe, where I can see what I'm doing. It's not covering my axis cavity also. So I'm only cutting at the entry point. In short, my lateral compaction is almost complete. But the obturation that I am looking for is not complete. What I'm asking you is, please melt the gadapercha at the root end, the last 3 to 5 millimeters. That's my 3-dimensional obturation. What we have done at the entry point here is also a thermoplasticized obturation. But you know what? The obturation of thermoplasticized has happened at the top, at the coronal 1/3. The rule goes this way. When you take a GP point and touch hot instrument to the GP point will soften and then you'll compact. That's called the wave of condensation. That GP point that softened gets molded. The 3 to 5 millimeters of GP point gets condensed to the dimension wherever it wants to slip in. Think of this concept. What we were all doing before at the entry point, if we shift our mind and the technique to the root end, won't we cock it better? That's what I want you to start thinking. Try and do the root end. That's what I'm going to show you in the couple of videos to come now. I've done the lateral compaction. This is an urgent case for a Western patient who came in who didn't want to change the crown, I had to go through the crown. Otherwise, I don't prefer keeping old crowns. Anyway, coming to the technique, I will take a hot instrument with the stopper. You see the stopper here? Stopper is already measured. If the tooth length was, say, 20 millimeters, my stopper is not more than 15. It's 14 or 15. My stopper will go to the occlusal reference and stop there. I'll take a heated instrument. As I activate heat, in the same motion, my instrument will straight go down up to where I want to go, stop, wait for 10 seconds, give a short burst of heat for 2 seconds, hit it north, south, east, west, and take it out. When I do that, the entire root canal that was filled like a lateral compaction, now what I'm doing is I'm taking a heated plunger straight till the full part of the canal, the straight part of the canal, release the heat, let it cool. Once it cools, I want to detach it, right? That's why I give a short burst of 2 minutes heat, 2 second heat, 2 second heat. Cut it, I said north, south, east, west. Actually, it's also known as buccolingual mesodistal. And then take it out. That's exactly what happens in this video. See this? We're going straight down with this heated probe, a downpacking instrument, till the point of my reference, stop. This will happen within 5 seconds or 10 seconds. And then when I pull it out, see that apical third GP point is left behind, the rest has come out in the hot instrument that I used. I don't need this. The GP point that has gone in, which is molten now, at the apical third is where I manipulated to make it a 3D apical sealed obturation. So let's see a clinical case. Here's a retreatment that I had to do. The first X-ray, again, is a little cone cut. I'm sorry for this. This was referred by a friend of mine. I used his pictures. But for documentation, I know you need to have your own pictures. Fine. A model work here. This is a true tooth model. We're trying to do a down pack there. See this? The first searing I did here. Now I'm going straight down after this step up to where I want to go. Stop. Short burst of heat. Move it. Take it out. GP point comes out what I don't want. What's inside is inside, and I give a 3D packing. This is, of course, a model. But if you see here, you know what I did? I know there's an apical split here. There are two ways of filling it. Either take two small GP points, fill one and fill the other one. I didn't have a heated point like a plugger tip that was reaching till there. Because I told you to select a downpacking instrument or even the cold pluggers, you need to select it before obturation to see up to where it's going. Adjust the stopper, take the other side, adjust the stopper. That's how you make your instrument kit ready before obturation. Now see what happens. That GP point which has gone till there, I deformed it some more and we get the apical splits. This is the principle of hydrodynamics. Under pressure, one-way traffic, it is nowhere else to escape. But if you're not cleaned and shaped well, mostly cleaned, then it's not going to go there. It's going to have plugged of debris or mud, right? So it's going to stop where it's supposed to stop. I want it to go deeper, right? This is what is known as downpack. So another case here. I know there's a bulbous root, hypercementosis was there, multiple canals for sure. We cleaned it well, and see when I completed what happens. Did a downpack, and you ended up getting branches. So these are the kind of cases you should try and achieve. Because when you know an infection is climbing up the root, please expect multiple canals, multiple lateral canals. There's a high chances and possibility. In this tooth, we didn't have to do a backfill here. You know why? I did a downpack. I didn't have to fill the remaining case. I just put a post and we completed the root canal. Now here if you see, there are doctors, you may ask me, I don't have a molten Gadaparcha filler like a backfill. Can I please use just the Gadaparcha again and fill it? Why not? So you can do a downpack and fill the whole root canal if you want. You don't have to always use a backfill. When I say backfill, it's this way. In the books, when we read, we didn't read much as downpack and backfill. We read it like, say, System B and Obtura. When I say Obtura, you'll all remember. Obtura is a company name, actually. It's like talking like a Coke or a Pepsi. We don't call it Cola or Xerox and Photostat. You know how it is. The company name got so popular. But actually, we have so many companies. What I have in my clinic is Elements. What I have in Cordless is also a BNL. What I have is also a Denjoy. So what you could do is you could buy one of these. But firstly, for beginners or young doctors who want to just get into the act, please try and throw the heated excavators, what you want to use, or burnishes out. Buy at least an endodontic pen, the heated pen. This is called a gun. So I want you to understand, you don't need a gun like this all the time. What I want you all to understand is, at least by the pen, do a down pack. The apical third is done. The root canal is going to be successful. The remaining part, if it's less filled, underfilled, I'm not asking you to do that. But by mistake, if it happens, you may still be lucky. Because literature says that the highest amount of lateral additional accessory canals are only in the apical third, not at the middle and the coronal as much. But it's like this, if your restroom is clean, your bedroom and your drawing room has to be clean. So if you cleaned your apical third and filled it up well, I don't think there's any clinician who will not do the middle and the top well, all will end up doing it well, right? Anyway, so backfill, there are many devices. So this is down pack and a backfill, down pack and a backfill, down pack and a backfill, down pack and a backfill for various teeth. Now, those are different devices as different twin devices. Can you buy this? These are all in one. There's a down pack and a backfill in one device. All those I'm showing are the ones that I've used. I have them. Elements is what I have in my practice also. There are two in one machine. I also have these. I've used this. I don't have these now, but I have these. These are cordless devices. But I prefer a cordless to a corded one, if you ask me, because they're so convenient to carry and use. And I also use multiple of them. The reason being, if I want two tips of down pack or two tapers, I don't want to waste my time changing it. I will just change the handpiece itself. I'll ask my assistant to give another one to me. Okay, squirt technique got popular. Is nothing but one of the ways backfill is done. A gun you saw where you put a pellet, or there's a pre-ready-made pellet which gets heated up. The pellet is warm. You press a trigger and the pellet will flow gadaparcha into this needle tip and into the canal. So that's the way the flowable gadaparcha works. Flowable gadaparcha is easy to use, provided you can see it well. For all those who are using microscopes, I'm sure you are all using by now. If you have a microscope, I'm sure you're doing it. For those who are using loops, second best to none, you can still do it. But if you're using a naked eye, I think you may not do it 100% good. But try and understand that for a flowable material, you need to have different gauges. When I say gauges, it means there's a high, medium, low, 20, 23, and I think 25 gauge. Depending on the canal volume, is it small canal or big canal, how much the flow you want. That's when you'll select the type of the gadaparcha that you want to flow. But there are some tricks in that also. I'm coming to that. So we'll see that a small demonstration here. These are Buchanan pluggers here. I'm going to show you a demonstration here again. So I'm trying to use a master cone. So that's the master cone that we put. And that's the down pack instrument I cut at the entry point. So I'll select a pre-size, pre-fit plugger. One I'm going to heat, and then a cold pluggers also. Now we take that and straight away sink it in till there. So my apical third is left behind. And the gun is taken out. I will condense it well, and that's where I'll complete I'm condensing it. See this? My down pack is done. I'll take a gun. The gun is sunk into the old gadaparcha so that it gets a little heat of that, so it melts and the continuity is maintained. If you don't do that, there'll be a break in the continuity. So touch a little hot into that, heat into that, and then you use the gun to fill it back. So that's what we did there. Please do it in layers. If you do it in one shot, you might end up having voids, bubbles, or irregularities or drag. So just a few drops, condense it, a little more, condense it, a little more, condense it, and that way it goes. So that's the backfill. So this is a step-by-step technique of a down pack and a backfill, and you see that there also we managed to get a lateral fill. And the last layer I'm trying to fill in this block. Sometimes I stop it here because I want 2 millimeters of core built up into the canal. Like I said, a resin that goes into the canal in different directions and different canals can act like a short post. That's another advantage. So try and fill that canal that way. It's a slight overflow here and try and condense it. Okay, squirt technique truly means, suppose I want to use a bioceramic material or an MTA on the root end for that plug. The canal diameter should be at least 70, 80 or even above. In curvatures, it's so difficult to manipulate it. So what I'm trying to show you is, on this radiograph here, even though this is an extracted tooth, we have chopped it, we have mounted it in putty index. So here you see the GP points are suiting beautifully. But this is the radiograph we get to see in the mouth, right? We don't get to see these, but there are spaces here. See this? This is purposely a chopped tooth. So in such cases, if the canal diameter is not 80, but like say 50 or 60, and you don't know if you're going to get a good cross-sectional circle, that's when I would say, please use a squirt technique. But to do that, you have to master it. You have to have visibility, which means you have to have magnification, good illumination, which is a microscope. It's a must to have a microscope to do a squirt technique. You have to deposit few drops, a little flow like a pea size, and gently condense. You can't do hard condensation, it will go beyond. When you condense, you have to start condensing little by little, gently and then firmly. That's how possibly you will start getting the apical plug of 2 to 3 millimeters onto this block. Of course, this is a model work. This is what I show my workshop candidates, the doctors who come there. But see here, from here to here, it looks nice, 3D obturation, but see here, this is what I'm talking. The root canal GP point would have been circular, but this cross sections, most of the times, root and cross sections are like our eyes. They are teardrop, they're dumbbell shaped, they're draggy, they're not circular or a perfect round, they're oval at times. So your Gadapacha does no good. 2Ds are a false sense of satisfaction. So please believe in this. If you can cork it this good, I think you're there to stay there, you know. Right. So we started this case. We did a down pack, and then I ended up doing a backfill and completed the case. Look at this. From here, the split hasn't happened. Split happened till the root end, and that's how you possibly got with that single bulk of mass of Gadapacha to go there. We didn't put 2 Gadapacha cones, I told you before. So that's how you do a down pack and a backfill. Cases like this is a C-shaped canal. Again, see the cross section. I'm just trying to show you some pictures. See the cross sections. They're never circular. And just to see this isthmus here. Another picture. I can just show you so many obturations. When you see the cross sections of these teeth, it'll show you and tell you that they don't match that well. So please try and understand all that you see. Another C-shaped canal there. This is a C, total C, perfect C. So we need to understand this. Right. 2 more obturations before we go. What we need to understand is a quick view on this. In India, it's not as popular, but there are some things called core carrier-based obturations. In the Western world, in the US, in the insurance-based companies which supports the dentists, they use it in common. The reason I'm telling you is, I've got calls from dental friends of mine asking, Vivek, I started doing a repeat root canal and I see something black in between with GP. What is that? That's the core carrier, which means these are core carrier-based obturations. This is a plastic core. Earlier it was metallic. Now you get cross-link polymer also, but it's still a plastic. It can be removed easily. Don't worry about that. But it's a central core with a GP. The whole stick is taken in an oven, heated, then taken onto the tooth, and then worked. So you have a plastic core coated with gadaparcha. There are some ovens from different companies. These are the ones I've used. Take them onto the oven, leave it there for the prescribed time of 25-30 seconds or a little more, with the help of a locking plier, straight into the tooth, and then you place it. I'm going to show you two different procedures here. On the blog, I have told it good and bad. In the good, everything looks nice. In the bad, lateral canals have not been opened. There's a lot of debris. Apical gauging has not been done, and there's a lot of extrusion happening. Imagine hot material flowing beyond. It can be an irritant. In addition, the trick is, I know there are verifiers, but still you can't possibly get the perfect thing that you want. Second disadvantage in this technique is what? You have to go quick. You have 20 seconds, 15 seconds. You have to go firm without twisting and talking. You can't tuck the side. If you do that, you'll end up stripping the plastic. And if the plastic is stripped, on the top you may be lucky. As you go to the root end, if the plastic is stripped, there you're calling for trouble. The seal is going to break in no time. So try and see that if you want to use these, master it outside first, please. I know there are verifiers. These are the newer carriers from Gada core, it's called. These plastic core carriers earlier could not be cut, though we had the preppy burrs. So in case of post and cores, they were difficult. But the newer ones like these can actually be cut nicely and easily. That's why they are called Gata core. Again, the same trick. Heat it in the oven. One straight stroke, go in up to, it's of course a block, a model. Go till there. Confirm everything is good. Wait for a minute till it hardens and cools. Once it's cooled, remove the excess out. That's how you do it. Cut off at the entry point and you're sorted. Fine. One of the last obturations are like this. If the canal size is larger than 80, you can't go for a rolled cone or an inverted cone. I've tried a lot of these in my postgrad days or my early consulting days. Sooner or the later, that's why the minimum or the apt diameters have come in place for the canal preparations. Now, is it 25, is it 30 or 35? You can debate. That's not the topic today. The topic being, if there are larger diameter, the cross section between the dentine, the sealer and the gadaparcha is too large to prove success. Somewhere there can be a breakdown where bacteria can enter, and again the whole process of reinfection may start. So in such cases, when I have a canal size cross section as 0.8 millimeters here at the root end, I do not do these techniques anymore. Long gone. Last 20 years, I don't remember doing this. These are my old cases. What we would want to do now is, in cases that I've got larger cross sections, no gadaparcha, or canals that have got flare like blunderbuss, with a neck that are constricted like an isthmus, please try and manipulate a bioceramic material. In the block, I'm manipulating an MTA, but in this clinical case, where this young boy has lost 2 teeth, sad, I wanted to save his canine. He wanted to extract that. I wanted to save it and then maybe go in for a surgery later. But we did a bioceramic material like biodentine there. We did a flowable gadaparcha there. Here in this block, I took 1 stroke to fill it because I can see what I'm doing. Never do that in the clinical condition. Please divide that into segments. Apical third, middle third, coronal third. So MTA being the apical third, here I use biodentine as an apical third, a bioceramic material. A flowable gadaparcha, and then I used a flowable core material. That completes the entire hybrid obturation. That's what's called hybrid for me. Or a quick case here, 80 size, clean, paper point drying. I put calcium hydroxide definitely in areas where bioceramic material is going to come in. It's not a one visit for me. It has to be neutralized with calcium hydroxide. Once it's neutralized, after a couple of days, preferably about 10 to 12 days, I wait, wash off the calcium hydroxide, and then go in for the next material. I've used a laser also here, and then close it with a good temporary dressing after calcium hydroxide. This is glass enema. Then we reopen it. See the scale. There we did that, and this is the day we obturated with MTA and built up, and this is the day the fiber pore score was built up also. All I'm going to show you here is MTA was used in this case. I'm going to show you two examples, one of MTA and one of biodentine. This is very opaque because it's got bismuth oxide, that's what it said, and see how it's healed. What I'm trying to show you here is, see this lesion. It's a huge lesion here. And this is not a pre-op, this is intra-op, which means the day we put a bioceramic material. 18 months from there, I took a follow-up and see this. This is the best compliment a good clinician can get. Reversal of the periodontium, the healing that's happened. That's a nice feeling that you can have, you know. Right. I'm going to show you the small video here where we started this procedure and did the procedure. I'll just advance the video because you've already seen this video. I'm just packing biodentine at the deepest layer. Though it looks the same color, it's less opaque. I've used absorbent paper points to dry them and also as a condenser. You can also use GP point. You can also use pluggers to condense it. Absorbent paper points I've stopped using because the fibers are left behind sometimes. So we see here the fibers in that can be a little dangerous as a foreign body. Even this cotton movements I don't do anymore. This is an old video again when biodentine came about 8 to 10 years back. So I put the first layer here. So if you see here, now we are coating the sealer. The condensation was done there, and that's where we are. This is the day that you manipulated. Next appointment, definitely I'd like to wait for a couple of days. Studies say minimum is 24 hours. A good is about, again, 2 weeks is what they say. Once you're done with that, put some sealer, use a flowable material. Oval shaped canals using lateral compaction, a lot of GP will go in, a lot of time will go in. This is just inject and just fill it up. So it's that much easier. So it's not difficult, but in layers, step by step. Don't overfill it. You'll see the sealer also getting thrown out as it's getting filled out. It's like how you, when you inject the gun, don't lift the gun, please. It's like how you put elastomeric impression, a rubber-based impression around the finish lines. You don't lift the gun, right? The same way. You just let it hold there and let the gun get passively lifted out. That's how you do a backfill. And slowly start condensing it. When you condense it, don't do it here, there, everywhere. You'll get voids. Just do an overlapping technique and try and fill it up that way. So that's the way we have completed this case step by step. A picture here on biodentine, because I showed you MTA, I'm showing you bioceramic now. Obturation is done, slight overfill of the material there you see. I'm okay with that. What I'm trying to show you, though it looks white, it looks less opaque. And after 3 months, you see this, we have a post-op follow-up from there to there. It behaves so beautifully, it starts healing. That's the beauty of these bioceramic materials. Infection reversal. So just to revise the whole technique, a very good irrigation protocol, down pack, backfill. Of course, this was a dense invaginatus case, one of the most difficult cases that I've ever treated, and I got to treat early in life, which is maybe I think 2007 or 8. So I think it's 13 years old. In the department we did it, but we ended up getting this rhomboidal cross section filling there, a type 3. That's a dense. So this is a revision or a recap of all what we did. A down pack, a backfill, MTA. These are the obturations that I would prefer in these days. Maybe not when COVID days are going on because I want to be quick. So today my favorite choice of obturation is definitely a bioceramic sealer with a single cone with an additional cone just to pack it on top. Sear it at the entry level like a lateral compaction and I'm done with. After the obturation, please spend some time cleaning it on the same day. How fast can you do the core? The reason being as soon as possible. I took an applicator tip, like a bonding agent brush, rub it nicely, use an alcohol. You can also use some of them, you may be using any one of those sandblasters, alumina particles, good enough. But see that you clean it well. After that, etch it and bond it and use a flowable material. In doubtful cases, difficult cases, I would request you use color core at the deepest layer. Ultradent will give you this purple color, Bisco will give you this blue color. Buy what you want and do the core built up step by step. Packable, flowable, choice is yours. Right? So this was the C-shaped canal. See how dirty the canal looks. If you think I'm going to do the core built up next time and I'm going to clean it next time, you only have to use a lot of ultrasonics and burrs to remove this. It's not possible otherwise. But on the same day you do, you can come that much close to cleanliness. It's that clean. See this? You can get it so well and clean. So that's a request, because your worry would be what? The sealer is not set. How can I use liquid immediately? Even if you have prepared a root canal so well and you're irrigating the root canal, studies on irrigation say the irrigant will penetrate only 150 microns into the dentine. 1000 microns make 1 millimeter. So you're still at the entry point at 150 microns, don't bother. The root from there till the end is about 10 or 15 millimeters long. So it's about 10,000 microns, 15,000 microns far away. Your seal won't get disturbed, don't worry. Just go ahead. And that too, if it's a resin sealer, you're sorted, you're good. Right? Okay, as I conclude, I'm going to show you one case. Now, this is a review case done by my postgraduate. We take up these cases just to review the cases. He showed me the post-op. It looks nice. He used a lesser tapered obturation, maybe a 4%, maybe a combination of hand and 4%. Fair enough, he's gone to good length. But a take-home message is, if you see the pre-op, first my question was a root canal needed? We have to be more holistic. Okay, this is a very old case. Justified, you did a root canal. Now that you've done a root canal, please complete it well. Let the post-op be the pre-op. In the sense, let the pre-op not be the post-op, which means there's no infection here. And as you complete, you've developed an infection. What might have gone wrong? It's not about the obturation, don't get me wrong. Obturation, nothing to do with it. Everything except the obturation maybe, including the obturation maybe, has gone wrong there. So it's all about getting your discipline right, your protocols right, and your parameters right. Another case of mine. In consulting practice, highly diabetic patient, many reasons, but I stopped at F1 because I wanted to do my costing. I didn't want to go to F2, F3. And I stopped at F1. Obturation looks nice. I was happy about it. The patient comes to me with a larger lesion a year later. 1 year later, the lesion from there has grown to there. See that? I told the patient, I'm sorry, we could do a retreatment. It also can be a coronal leakage, which is not my case. The core built up and the crown was done by the dentist who was calling me for consulting practice. Anyway, we'll not talk about that. It failed. The patient didn't want a repeat. He said, I want to go for a surgical where I know an oral surgeon. If we would have done the surgery, we would have done a root end preparation, root end filling, and then, of course, taking care of it. The surgeon did it this way. He resected the mesial root, resected the distal root, and did something known as a cold burnishing. If it has failed in smaller diameters, if you have chopped it and not taken care of the root well, believe me, it will fail faster than before. This case went for an extraction in no time. The lesion only went on increasing. And here it is. See this. So all I'm trying to tell you is, if you don't understand what you're doing, if you don't understand the apical anatomy, this is one of my junior PGs with my late professor, Dr. Kamath, who has done this, is no more, of course, due respects to him. They have taken up the study, premolars, decalcified, India input, and see this apical anatomy. We are still the main canal dentists. We are good to go with the GP point till there. Are we good to clean and shape and prepare and fill these parts? If the answer is yes, you are here to stay. That's a good clinician. So a few quick pictures to show you. Everybody feels the distal canal is easy. Between the mesial and distal, mesial canals are more conical, more circular. Distal is oval and oblong. It's not easy. See this clinical picture. Mesial may look easy, distal is not. With respect to not only obturation, but respect to shaping, The rotary file will not even come in contact in many areas. Same thing, see here, how are you going to clean this isthmus? How are you going to clean this extension? Circular canal on this is okay, what about this? So from the word go, at the starting point, if you don't start respecting the teeth, I think you're in for trouble. With these few points, I think, look at the larger picture. We are only at the tip of the iceberg. I purposely put a tooth there that don't see the iceberg there at the top. Look at the bottom of the root there. See how it looks. That's what you need to look at. At the end, towards conclusion, I'd like to do a little advertisement. One Dental is part of me. It's my baby, where we do an online. It's an online platform. It's one of the largest platforms where we have a lot of lectures by me and a lot of good clinicians who are like-minded. A lot of clinical topics. We have excellent courses. We have a lot of long lectures, short lectures. It's in for the last 4 years. It works on some free model and subscription model. You can teach on One Dental. You can advertise on One Dental. There are many things. So whenever I lecture, I ask the organizers to give me this opportunity. They've agreed to that. So anybody who's viewing me can take this coupon code. It's called One Dental World Dental Association. ODWDA is a coupon code for today. You get 30 videos for 30 days. You can register till the 1st of August. From then, you will get 30 videos. We've already launched this earlier also. For some of you who have already seen it, I think it will be a repeat. We are going to add in more content. Already you have more than 220 hours of content in that. They're mostly clinical content. How to visit? It's very simple. Go to the website, onedental.co.in, become a member, select the membership, add to cart. When you add to cart, you don't need to pay. You can add the coupon code. If you want to pay and buy some other membership, they are also available. But once you put a coupon code, you can proceed to a checkout and you become a member. With this, I'd like to thank all the people who are listening to me at this hour, especially in India or the eastern part of India, Southeast Asia. If somebody is there, it's midnight. I would like to thermoplastically sign off with my obturating material as a big thank you. So thank you once again for calling me here. And this is my last slide. I'm very passionate on my clinical endodontics as much as I like to teach it. I'm an academician also in a college. I also have a private practice. I try to blend both. And that's what I brought onto this platform. Thank you, Abhishek. Again, thank you, Akshay. Thank you, Anand. Thank you, Saurabh. And thank you, the entire team. A pleasure being here at this hour. I've never actually lectured at this hour in India, at least. Abroad, we've done it. But in India, this is my first time. Thank you.
Thank you so much, sir. It was pleasure listening to you, and whenever we listen to you, every time we learn something new. Always and always. I am practicing warm vertical compaction from almost 10 years now, but every time I learn something new.
So it is always great fun listening to you. I was waiting for your typical thank you with the obturation. I was just waiting for it. And I know you love obturation. You love teaching obturation like anything. So it was fun listening to you, even at this hour. So we have loads of questions. So I hope you have a bit more of time.
I can go on, not a problem.
Cool. Abhishek, should I take up some?
Yes, please.
So one question from Dr. Talal Al-Nalvi. A very nice presentation, Dr. Vivek Hegde. I'm not sure, but I don't understand why you prefer bioceramic obturation in the COVID era.
Hi, Talal. He's a very good friend. And he's been our constant guest in a lot of Indian conferences, like the APIC, which happened, like the IFIA that's going to come in later. So, hi, Talal. The only reason, Talal, the contact time that I want with my patient should be shorter. It is said that it's good if you have 15 or 20 or 30 minutes of contact. I know one visit endodontics cannot be done that fast. Or if it's a 2 visits, it's just an obturation and a core built up for me. We're not doing any crowns in these days. There's no work without a rubber dam. If there's no rubber dam, there's no other dentistry. I'm not talking about only root canals. The reason I'm telling you is when it's a bioceramic, it's faster obturation. When it's a down pack and a backfill, maybe I need a variation. No, a verification radiograph, I need to spend a little more time. Even if I can save that 5 minutes more, is what I want at these times. That's the reason I'm preferring bioceramic to the other obturation these days, because I don't mind stepping down one step. Like I spoke yesterday in another platform, I told it's like a game of chess for me. I don't mind stepping one step back to go 2 steps forward to win the game. So I don't forcefully work under the microscope all the time. I use loupes all the time. Microscope is my ceiling. I take it down, do a spot check, and I'm sorted. The reason being, the viral load is high, and they're told that when you speak, when you talk, when you work, the throw is so much, you need 1,000 viral particles to get infected. Today, a lot of patients are asymptomatic. We don't know who is what. So in such conditions, that's the only reason I chose. Thank you, Talal.
Thanks a lot, sir. It was actually much needed right at the current hour.
Yeah.
So one more doubt from Dr. Viren Patel. So how do you prevent frequent damage to the tip of touch and heat device?
Okay. See, we should understand one thing. These tips, anything that you heat and cool, they have a life. Like they're going to deform. But they don't get, they'll only spoil if you start hitting the dentine. Try and go from the center of the gutta percha, and when you cut, you can hit the dentine. It's easy to say you don't touch dentine. It's a blind procedure. But in spite of that, if you can be a little careful in manipulating the carrier, the downpacking instrument, it'll last a little longer. But yes, in no time, it'll get charred, it'll get darkened, it'll look black, but still it'll work for a good 500,000 cases, which means the costing of the tip is nothing. So don't bother about that. Yeah.
Thank you, sir. So one more question from Dr. Pooja Singla. Sometimes there is a gap left between the downpack gutta percha and the backfill molten gutta percha. How to avoid it?
Okay, this generally happens because you want to take a radiograph after your downpack, because that's the critical part. Now, when you're going for a backfill, the first part that has been condensed already is set. And when you start the second layer, most important trick is, especially in long teeth, see that the gun that has a tip is bent in a certain direction, that the extension of the last portion after the bend, that extension is long enough to go and land, it should land on the previous gutta percha. If the tip is hot and you contacted that old gutta percha that you condensed, you can't have the junction. If you're leaving it in the air and then trying to drop it there, there's a good chance you'll get the junction. There are a few small tricks. Earlier days, when technology, techniques, machines, machinery were not like the way we have today, that time we had this trouble more. So my teachers used to tell me, take some zinc oxide eugenol powder, mix a little sealer, coat a little sealer. Even on the gun, you can put a little on the tip outside, take it down and inject. So this gets coated with a sealer, and when you manipulate, I don't know if it's a sealer that covers it or the GP that goes there. Somewhere you're trying to mask it. But today we can see it with the microscope. Straight part of the canal is easy, and the downpack can only be done up to the straight part. You can't go in curvatures. Yes. So it's about a trick that you can manipulate and manage. It's possible. I know a few cases you end up getting. Suppose you get it. When you start backfilling it, take the downpack instrument. After it's cooled, remodel it. Modulate it again. Heat, touch it, remove a little if you want. When it is softened, condense it again. The problem is, these materials that get heated, cooled, they become very tacky. Then they don't behave the way they behaved first time. Like they say, the first is the very best for anything, okay? So that will only come with practice. If you want to master it, the reason is only one. My first 100 teeth, that's how I work. I take 100 teeth for any treatment, any retreatment, any broken file removal. That's how I learned it. Extracted teeth first, then model work, then come to simple patient work. Then you're there, You can't expect the first case in the mouth, inside a tooth, in clinical conditions, you're going to get the best work. I don't know, maybe you're a good worker. I'm just telling to everybody at large,
Thanks a lot, sir. Abhishek, any questions from your end?
Yes, question from Rasina Reddy. In case of anterior teeth, which compaction technique is preferred, sir? Lateral or warm vertical compaction?
In which
Upper
teeth?
anterior. Upper
Anterior.
anterior, sir.
See, there is no rule that you have to do tooth-wise. You can follow any technique. See, I'll put it this way. If you go to the research, lateral compaction is not a bad technique. It's comparable to even the 3D obturation techniques. However, 3D is what I believe. I wouldn't ask anybody to go for a squat technique because in the books we had read about obturat technique. If the apical matrix is not good, if the diameter is large, if you inject and if you condense, in my postgraduate days, I know what happened. Things were all over, okay? It's gone beyond. In the college, in the university, you are excused. In a private practice, your patient is not going to spare you. So please don't. When you take this down packing technique, you're using a beta cone. It's a hard gadaparcha cone where you're melting it. So very few chances will go beyond. If you think the seal is not good, you've not got a good tuck back, please snip it. Cut the gadaparcha by about 0.5 millimeters and then do the down pack. It'll go to everywhere. The reason I'm telling you is the last 0.5 or 1 millimeters may not be heated even in a down pack.
Right.
Okay, so the last 1 millimeter can be still many a times a cold lateral. But don't worry if you're not doing thermoplasticized. A down pack and backfill is definitely a preferred technique for most of us, but start with lateral compaction. If you have got a good seal at the apical third and done lateral condensation or compaction, it's time consuming, but it's a acceptable technique.
Okay. Sir, another question from Jagdish Babu. I am putting it on the screen for you.
Yeah.
He,
While I was removing the down pack instrument, most of the times the tip alone comes out instead of cutting the GP with it. Please explain what. Okay, what he's telling is when he was trying to sear the GP point or cut the GP point at the apical third or the middle third junction in the straight part, the whole thing came out. It happens. It happened to me also. Don't worry. It happens to everybody. Initial years, we all go through it. Now, if it happens, that means you are alive and you're working. Okay. Don't worry. So the thing is, if it happens, that's when you ask me a question, that means you are eager to learn it. Few reasons. You know what? Either you've not manipulated the heat in the right way. I said heat the instrument to the prescribed temperature. It can be from 180 degrees or 150, 180, 200, 230 up to 250 maybe. So based on the canal volume, you need more temperature. Larger the canal, more temperature, right? Most important thing is the plugger that is chosen to heat it, the downpack tip. If you take a very thin tip on a large canal and you want to go and cut it, and you're not seeing what you're doing sometimes, the whole thing gets cut off. But if you cut it, and sometimes, okay, I'll put it this way. Herbert Schilder didn't do a downpack. In his vertical compaction, he removed it little by little. Start there. Little by little, compacted. Remove little, compacted. Remove little. Ultimately, you're reaching there. But the only disadvantage will be, you know what? You're giving heat to the dentine too much. The tip that gets heated to 250 degrees is too much for a GP. GP does not need that much heat. But you have loss of energy and many other reasons when you go there. If you take so much heat, if you are more than 5 or 10 seconds in the canal, the tooth is going to get heated up, which means in clinical conditions, there's a PDL ligament, the periodontal ligament that holds the tooth to the bone. That will get damaged. So be even little by little, keep short bursts. You have 10 seconds to do what you want to do. So most common reason is that, where you use a smaller instrument in a larger canal. Or even if things are right, your searing has not happened well. That's the reason, yes.
Thank you so much, sir. Most of the questions have been answered.
Yeah.
We have left some questions, but they are already answered in the lecture. Those who have missed some answers, I will request them to watch the lecture again, and they're definitely going to learn more things.
much more.
I think we should watch this lecture twice.
Yeah. Thank you.
Surely. Thanks a lot,
Sir,
sir. It was an amazing session. Abhishek, any
Thank you.
questions?
Yes, one last question from Jagdish Babu once again. I'm putting it on screen.
So my question is, after down pack at 5 millimeters, the remaining coronal GP is not coming along with down pack tip. Instead, only tip comes alone. Yeah, that's what exactly I was telling. Either the whole thing comes out, or sometimes only your instrument comes out. The reason being, I think your tip size was smaller, or up to where you've gone, you've not seared it, you've not cut it well. I told you north, south, east, west, or maybe mesial, distal, buccal, lingual. So you take the hot instrument in 10 seconds, reach where you want to reach, leave it alone for another 10, 20 seconds, let it cool. Give a short burst of heat, just 2 seconds, cut it out and try and lift it out. If the tip is too small and there's a lot of space around, tip will come. If you not cut, the tip will come. I'm not saying the whole thing will come. Whole thing also may come, the tip. In such cases, what you do is, you're finding it difficult in some cases, like I said, start searing only little by little from top. Maybe you need a broader tip, but cut little, pack, cut little and pack. That's not a bad idea. You still will reach there. Like they say, there are two ways to reach one place, right? Choose whichever suits you that day.
Thank you. Thank
Sure.
you so much.
Thanks a lot, sir. It was an amazing, crystal clear lecture. I think so. I don't think so. We could have heard anything better than this on obturation for sure. It was
Thank you.
amazing to have you, sir. Thanks a lot. Abhishek, any announcements?
Thank you so much, sir, once again. And definitely we are going to follow you on One Dental.
Thank you. Thank you so much. I appreciate it. Yeah.
Thank
For
you
sure.
so much, sir.
Right. Thanks.
So-
Thank you.
Bye-bye, sir. Good night.
Yeah.
And the
Bye-bye,
questionnaire
everyone.
has been uploaded by Dr. Anand, and you can answer the questionnaire there. It will be open till the next session.
Yes. So we'll meet again on the 26th, that is the Sunday at 9 p.m. with Professor Dr. Raghu, who will be talking on post-in course. Bye, everyone. Good night. Bye, sir.
Bye. Good night. Bye.